It turns out that what many assume about personality and mental health, that they are fixed early in life or solely the product of unconscious conflicts, is completely backwards.
Really? That's quite a shift from what a lot of people think, especially given how much Freud's ideas have permeated popular culture.
Exactly. Instead, multiple dynamic models show personality and mental health as evolving, influenced by conscious and unconscious processes, learned behaviors, cognitive patterns, interpersonal relationships, and biological factors.
Wow, that really changes the way we think about assessment and treatment in psychiatric nursing, doesn't it?
It does. Because how we understand mental illness and personality development directly shapes how we assess, engage with, and treat patients. It affects everything from therapeutic relationships to intervention strategies and even how we address stigma.
So by the end of this episode, listeners will have a richer, more integrated understanding of the major psychological and nursing theories that underpin psychiatric mental health nursing practice, including their nuances, clinical implications, and how they inform evidence-based care.
Right. So let's start with the foundation, Freud's psychoanalytic theory. Even though some of his ideas have been challenged or evolved, his concepts of the unconscious, personality structure, defense mechanisms, and psychosexual stages remain influential.
The iceberg metaphor is such a vivid way to understand Freud's levels of awareness. The conscious mind is just the tip, the preconscious is just below the surface, and then there's the vast unconscious beneath, holding repressed memories and drives that influence behavior without our awareness.
Yeah, and that unconscious part is huge. Freud believed that much of our behavior is driven by these hidden forces. It's like an iceberg. You only see a small part, but the bulk is underwater, unseen but powerful.
And then there's the personality structure, the id, ego, and superego. The id is all about primal drives and the pleasure principle, present from birth.
Right, the id is impulsive, illogical, and demands immediate gratification. Think of a screaming infant who just wants what it wants no matter what.
Then the ego develops around 4 to 5 months, acting as the reality tester. It negotiates between the id's demands and the external world.
The ego follows the reality principle, telling the id, hold on, we can't just have what we want right now. It's the problem solver, balancing internal drives and external constraints.
And finally, the superego, which represents the moral conscience, internalized from parents and society. It strives for perfection and judges our actions.
Exactly. The superego is like the internalized shoulds and should-nots. When it's too strong, people can be overly self-critical or guilt-ridden. When the id dominates, impulsivity and lack of control can result.
So the balance among these 3 components determines personality health. That's a useful framework for understanding some patient behaviors.
Definitely. And then there are defense mechanisms, which operate unconsciously to reduce anxiety by distorting reality. They're essential for survival, but can hinder growth if overused.
Like repression, denial, projection. These mechanisms protect the ego from painful feelings or thoughts.
Right. For example, a patient might deny the severity of their illness to avoid anxiety. But if that denial persists, it can interfere with treatment.
Freud's psychosexual stages also emphasize how early childhood experiences shape personality. Fixation at any stage can manifest in adult behaviors.
Yeah, like oral fixation linked to dependency or sarcasm, or anal fixation associated with rigidity or messiness.
Though classical psychoanalysis is rarely used today because it's so lengthy and costly, concepts like transference and countertransference remain vital in nursing practice.
Transference is when patients project feelings onto the nurse or therapist that were originally directed at significant others. Countertransference is the nurse's unconscious reaction to the patient.
That's why self-awareness is so critical for nurses, to avoid letting personal feelings interfere with care.
Exactly. In psychodynamic therapy, a modern offshoot still focuses on unconscious conflicts and relational patterns, but requires advanced training and is time-intensive.
So from a nursing perspective, understanding unconscious influences helps interpret complex behaviors and engage in therapeutic communication, emphasizing attentive listening and exploring underlying themes.
Well put. Now, moving on to developmental theories, which provide frameworks for assessing age-appropriate behavior and identifying arrested development.
Piaget's cognitive development stages are foundational here. starting with the sensory motor stage from birth to 2 years, where reflexes develop into purposeful movement and object permanence emerges.
That's why games like peekaboo are so delightful to infants. They're beginning to understand that objects exist even when out of sight.
Then the pre-operational stage from 2 to 7 years, characterized by concrete thinking and egocentrism. Children can't yet think abstractly or conserve mass or volume.
Like when a child thinks a tall, thin glass holds more liquid than a short, wide one, even if the volume is the same.
The concrete operational stage from 7 to 11 years brings logical thought, perspective taking, and conservation.
Children can classify objects, understand reversibility, and see situations from others' points of view.
Finally, the formal operational stage from 11 years onward involves abstract reasoning and problem solving, similar to adults.
These stages help nurses tailor interventions. For example, preschoolers in the pre-operational stage respond well to play-based learning.
Erickson's psychosocial stages extend development across the lifespan, emphasizing social and cultural influences.
He described 8 stages, each with a crisis and 2 possible outcomes. For instance, trust versus mistrust in infancy, identity versus role confusion in adolescence.
Successful resolution leads to virtues like confidence, purpose, fidelity, intimacy, generativity, and integrity.
Failure results in difficulties like mistrust, inferiority, role confusion, isolation, self-absorption, or despair.
Kohlberg's moral development builds on Piaget, describing progression from obedience to universal ethical principles.
His stages move from pre-conventional levels focused on obedience and punishment to conventional levels emphasizing social order, and finally post-conventional levels where social contracts and universal ethics guide behavior.
Carol Gilligan critiqued Kohlberg's male-centric model, emphasizing an ethics of care that values relationships and putting the needs of loved ones above abstract justice.
That's important for nursing, as it highlights different moral reasoning approaches and the need to consider relational contexts.
Clinically, nurses use these frameworks to tailor interventions. For example, adolescents struggling with identity issues may need support in exploring self-concept.
And understanding moral development aids in ethical decision-making and patient advocacy.
Moving on to interpersonal theories, there's a shift from intrapsychic focus to observable interpersonal processes.
Margaret Mahler's object relations theory emphasizes the early mother-child relationship as critical for developing a differentiated self.
The concept of good enough parenting balances holding the child enough for safety while encouraging independence.
Problems in this separation individuation process can lead to psychological difficulties later.
Harry Stack Sullivan's interpersonal theory defines personality as behavior in interpersonal contexts.
He saw anxiety as arising from social insecurity and introduced security operations as unconscious strategies to reduce anxiety.
These security operations are similar to Freud's defense mechanisms but focus on social interactions.
Sullivan emphasized authentic, mutual relationships, which is foundational for therapeutic relationships in nursing.
Interpersonal psychotherapy, developed by Meyer and Sullivan, is a short-term symptom-focused therapy improving interpersonal functioning.
It targets relational disturbances that maintain psychiatric symptoms, especially depression and anxiety.
Hildegard Peplau's theory of interpersonal relations was a paradigm shift, viewing nursing as a collaborative, educative process rather than just medical treatment.
Peplau saw nurses as participant observers, balancing self-awareness with patient focus.
She also described how anxiety levels affect perception and learning, promoting interventions to reduce anxiety and improve functioning.
Process recording and communication skills are key tools in this approach.
The title model builds on interpersonal theories, emphasizing storytelling, collaboration, and respect for the patient's experience as central to recovery.
Therapeutic relationships are central to psychiatric nursing, and nurses must maintain self-awareness to avoid countertransference.
Group therapy, family interventions, and milieu therapy are practical applications of interpersonal theory.
Speaking of behavioral theories, behaviorism rejects unconscious motives, focusing on learned behaviors shaped by environment.
Pavlov's classical conditioning showed how involuntary responses are learned by association, like dogs salivating at a bell.
A human example is feeling nauseated at the smell of a food that once caused illness.
Watson's behaviorism emphasized personality as learned behavior, demonstrated in the Little Albert experiment where fear was conditioned.
Skinner's operant conditioning focused on voluntary behaviors shaped by reinforcement or punishment.
Positive reinforcement increases behavior, while punishment or extinction decreases it.
Behavioral therapies include modeling, where patients learn by imitation.
Operant conditioning underpins token economies, rewarding desired behaviors with tokens exchangeable for privileges.
Systematic desensitization involves gradual exposure to feared stimuli paired with relaxation.
Aversion therapy pairs maladaptive behavior with unpleasant stimuli but requires careful ethical consideration.
Biofeedback uses physiological data to help control stress responses.
Clinically, token economies are common in psychiatric units to encourage self-care and social participation.
Role-playing teaches social skills, and ignoring negative behavior can extinguish it.
Behavioral models provide concrete, measurable behavior change without requiring insight into underlying causes.
They're effective for phobias, addictions, and chronic mental illness, but ethical considerations are critical, especially with aversion therapy.
Cognitive theories focus on the interplay between thoughts, feelings, and behaviors.
Albert Ellis's rational emotive behavior therapy identifies irrational beliefs, those shoulds and musts, that cause emotional distress.
His ABC model, activating event, beliefs, consequences, helps patients recognize and change dysfunctional thinking.
Aaron Beck's cognitive behavioral therapy combines cognitive and behavioral approaches.
Beck emphasized schemata, core beliefs about self, others, and the world, that shape automatic thoughts and cognitive distortions.
Common distortions include all-or-nothing thinking, catastrophizing, personalization, and emotional reasoning.
Therapy involves identifying, challenging, and restructuring these distorted thoughts.
Homework and behavioral experiments are key components.
For example, a depressed patient challenged her belief, "I am ugly," through evidence and behavioral experiments, leading to improved self-esteem.
Dialectical behavior therapy, developed by Marsha Linehan, targets emotional dysregulation and borderline personality disorder.
DBT combines acceptance and change strategies, focusing on mindfulness, distress tolerance, emotional regulation, and interpersonal effectiveness.
Clinically, CBT is the most empirically supported psychotherapy.
Nurses can use cognitive frameworks to understand both patient and self-responses.
Brief therapies focus on present problems, rapid assessment, and concrete goals.
Humanistic theories emerged as a reaction against deterministic psychoanalytic and behavioral models.
Abraham Maslow's hierarchy of needs arranges human needs from physiological to safety, belongingness, esteem, self-actualization, and later cognitive and aesthetic needs.
It emphasizes human potential and self-fulfillment.
Self-actualized individuals exhibit creativity, authenticity, and fulfillment.
Clinically, prioritizing care according to Maslow's hierarchy ensures basic needs are met before higher-level interventions.
It encourages strengths-based, person-centered care and fosters patient autonomy and growth.
The biological model views mental illness as brain-based disease, akin to diabetes or heart disease.
Psychopharmacology revolutionized psychiatry, starting with chlorpromazine in the 1950s.
The focus is on neurological, chemical, and genetic factors, with treatment targeting brain dysfunction.
This model reduces stigma by framing mental illness as a physical disease beyond patient control.
Nurses administer medications, monitor physical health, and prepare patients for somatic therapies.
But caution is needed because the biological model alone neglects social, cultural, environmental, and psychological factors.
Additional therapies include milieu therapy, which uses the therapeutic environment, people, setting, structure, emotional climate as a healing tool.
Originated with Bettelheim's work with psychotic children, milieu therapy is a basic nursing intervention.
Examples include safe environments for suicidal patients or those with cognitive disorders.
Crisis intervention, group therapy, and family interventions are essential nursing tools.
Selected nursing theorists like Benner, Oram, Roy, Neumann, and Travelby contribute frameworks emphasizing caring, self-care, adaptation, stress management, and communication.
The title model emphasizes listening to the patient's story and collaborative care planning.
Cultural competence is crucial, especially when working with indigenous populations.
The two-eyed seeing approach integrates indigenous and Western knowledge systems.
Nurses must blend multiple worldviews and healing approaches to provide effective care.
So, in practice, nurses integrate knowledge of unconscious processes, developmental stages, interpersonal dynamics, learned behaviors, cognitive patterns, human potential, and biological factors.
Self-awareness and reflection are critical to avoid countertransference and maintain patient-centered care.
Evidence-informed practice requires understanding the strengths and limitations of each theory.
Prioritizing patient needs according to Maslow's hierarchy and tailoring interventions to developmental and cognitive levels improves outcomes.
Behavioral and cognitive therapies offer concrete tools for modifying maladaptive behaviors and thoughts.
Interpersonal theories underscore the importance of authentic, collaborative nurse-patient relationships.
Biological treatments are essential, but must be integrated with psychosocial approaches.
Psychiatric mental health nursing is a complex, evolving field that demands a sophisticated understanding of multiple theoretical perspectives.
By appreciating the nuances and clinical applications of these theories, nurses can provide holistic, effective, and compassionate care that meets the diverse needs of their patients.
That's a great note to end on. Complexity, integration, and compassion.
Absolutely. It's what makes this field both challenging and rewarding.